morning, everyone. This is Jennifer Lisanti, the Director of Sales at Beere&Purves. Thank you very much for participating in today's webinar. There's a lot of information we're going to go through. We're going to try to hit it all in 30 minutes, so thank you very much for your patience. The agenda today is listed here. The main topic for the agenda is legislation at both the federal and California levels. We have some information on some B&P news, meaning connectivity with eCentral, that we'd like to talk about as well. Real quickly, that means that we have recently rolled out connectivity on the underwriting side, and in June we'll be rolling out connectivity within BP Quote, which is Health Connect. So if you quote a group within Health Connect and then you are changing carriers, now in June you'll be able to quickly export the census data as well as the sold plans and rates into the new HIRS system so that we can quickly load groups. And then once the group has gone through their enrollments, then you can quickly send it through eCentral to B&P underwriting teams. And then lastly, we'll finish up with a short piece on some new carrier information. So having said all that, we'll go ahead and begin. The main thing from this webinar is, just like in life in general, there's constant changes. So, even as of yesterday afternoon, there were changes at the state level. So we are tracking all that. We thought it'd be a good time to have this webinar, and we'll continue keeping you updated in addition to the normal reps coming out to your offices and giving you updates. Do remember that we are on Twitter. Hopefully not as many live as interesting chats as some other people you'll see on Twitter, but we do try to keep you posted on the most information, especially we'll be adding the legislation in. We'll be adding information on LinkedIn as well. YouTube, we have sources there. And then we're also rolling out texting. And texting we're going to keep at a very minimal level because we don't want to annoy you. But we will be posting, or texting rather, pertinent rate information, network information, and of course legislation information as things change, like when things get passed, etc. And you can always know when to contact us, email us, reach out to us. We're always here for you. So a quick reminder on how a bill becomes a law. If you don't remember the details, and I was reminded of a quote yesterday, there's two things you never want to see being made, and that of course is sausage and legislation. So as a reminder that a bill can be proposed in either side of the Congress, either the House or the Senate. The federal legislation for us this time started on the House side. It was introduced, it's already gone through committees. They did eventually bring it to a floor action. It did pass through the House, and now it's been kicked over to the Senate, which is where we are now at the federal level. For the Senate, they're basically telling us they're going to start all over. So it is now just beginning that process on the Senate side. So it does sound like they're going to propose changes to what they received from the House. As a result, if they pass it on the Senate, it will get kicked back over to the House. If the House agrees on the changes, it'll get sent to the President to either sign or veto, and then it becomes a law. Most bills that are proposed every year never get out of the committee levels. So at the federal level, as I said, it's gone through the House, it's over at the Senate, they're just starting the process as we speak. And at the state level in California, it's starting on the Senate side, and it is currently being brought to a floor action, meaning a vote this week. So by the end of tomorrow, we should know if the California legislation that we'll speak to today proceeds over to the House side or not. So that's your review of our legislation and how it's all made. So where we're starting with is on the federal side, and so the House of Representatives have signed or voted on a law. It's 1628. It's called the American Health Care Act Bill. We'll call it the AHCA. So over in the left here, you're going to see that it did narrowly pass the House on May 4th, and that's after they had to cancel the vote in March because they didn't think that they had the votes, and at the end they ended up bringing some new amendments in that were able to get enough votes to pass it over to the Senate, and that's where we are today. Another quick reminder is technically, the Republicans have been wanting to completely repeal ACA for the past 7 years. However, even though it's a controlled House and Senate, they don't have the 60 votes that's actually required to completely repeal ACA. So the process we're in right now is called the reconciliation process, and that requires less votes, which means we only need 51 votes in the Senate to pass it out. However, that means we can only lose 2 senators because it doesn't seem like there's any Democratic support for various reasons. We could lose 2 senators because Vice President Mike Pence would be the 51st vote, would be the assumption to send it out. So that is where we're at right now at the federal level. I do want to quickly go through what has been passed by the AHCA on the House side. Now, I'm not going to spend a lot of time going through the details of it because you'll know that, especially since the Senate has actually told us they're rewriting the bill, a lot of the stuff that is in the AHCA passed by the House may change or be removed, added to, etc. But what is on the table right now is the first item is that they are going to state that they can't end the mandate because it doesn't affect the budget, which is what's key to the reconciliation process, but it can end the penalty. And the way it's written is it would actually not penalize anyone retro to December 31st of 2015, which means if you didn't have the insurance you were required by ACA in 2016, you wouldn't have been penalized on the 2017 taxes going forward. The second item is very contentious because this kind of goes into the pre-existing condition that people are very up in arms about nowadays. And that means the AHCA states if you go more than 63 days in 1 year without coverage, when you jump back in, you have to pay 30% more than you would have paid if you had remained in the system. So those people with pre-existing conditions are very concerned about this item here. The third bullet point talks about how the current subsidies with ACA would be replaced in 2020 by tax credits, and they're proposing age and income is what this would be based on. So you can see it starts at $2,000 for people under 30, and it increases during the age brackets up to a maximum of $4,000 for people over 60. And it could, they've built in there that they could add increases into what that cost is. So they do state that, hey, if you're making quite a bit of money, we're not going to pay you the full $2,000 or up to the $4,000 amount. We're actually going to phase it out. And then if you're making a certain amount, we're not going to give you the tax credit at all. So what that means is if you're 29 years old and you're making $70,000 a year, you would get the full $2,000 tax credit towards your insurance. However, if you're 29 and making $80,000 a year, you wouldn't make the full $2,000. You would make a lower portion than $2,000. And then if you're 59 years old and you're an individual making more than $250,000, you wouldn't get a tax credit at all towards insurance. The last item on the slide is the fact that the AHCA says that the cost sharing, which is actually not the premium subsidy, but the subsidies for when you actually use care for certain people under ACA, would go away effective 2020. Continuing on with what is included in this AHCA passed by the House currently is that it does end the employer mandate. Now, talking to most brokers that we work with, they haven't found that they've gained a lot of business from employers that were not offering group insurance before as a result of ACA. There's definitely some out there, but most brokers are saying that they didn't get a lot of business from this mandate, that most of their clients were already, of course, their clients because they were already offering group insurance. So that is written in there technically that the employer wouldn't have to provide insurance. However, since the reporting feature doesn't affect the federal budget, 1094 and 1095 forms that everyone loves would still remain because that has not been changed. It would remove actuarial values. Now this might be nice because it would give you some flexibility with those metallic plans. You know, the carriers are so restricted on how they can do plan designs, it has really removed any creativity or variances from one carrier to another. The third item here, most people support in the fact that it would end most ACA taxes, so which you can see the hit, which the insurance companies don't like because it's health insurance tax, medical devices, over-the-counter prescriptions, etc. Ironically, the most controversial tax, which is the Cadillac tax, was not removed completely in this. It was just postponed until 2025. And most people, employers, unions, carriers, etc., are against this Cadillac tax, but it's still there. And then the Republicans tend to like HSAs and FSAs, so they've made those more attractive in this proposed bill. It would increase the amount you could put into an HSA account to match the amount of the limits per year, which does make sense. Currently, the amount you can put in is actually lower than the limits of the HSA plan designs. It would allow spouses to also make additional contributions into an HSA. It would go back to allowing over-the-counter prescriptions to be included in HSA reimbursements. And then if you did take money out for non-medical purposes, currently through ACA the penalty is 20%, but prior to ACA it was only 10%, and AHCA would go back to the 10%. And lastly on this slide is FSAs. So like the HSAs, it would allow over-the-counter prescriptions to be included, and with ACA there was a limit of $2,600 that would be removed. The last slide as far as what is included in the AHCA is a fact, and this is extremely controversial, is it would end Medicaid expansion effective 2020. Now some Republican states actually expanded Medicaid under ACA, but not all, and this is a very polarizing point within the GOP party itself. So that's going to be, how do they resolve that within the Senate, et cetera, and that's actually what was causing issues with getting the House version passed. It would change the Medicaid expansion funding from block grant funding to the per person allotment. And really what that does is if the amount in Medicaid increases, they're not going to be getting more money for those members if they go out and then try to come back in. Also popular with the GOP is the fact that it would allow states the option to impose work or school requirements to get Medicaid. And then the last couple items are there. You can see one is creating, like a high-risk fund reimbursement of $138 billion in a couple ways. So the last item here are the 3 waivers that you may have heard about. So in AHCA, the states are given permission to request waivers. And those 3 waivers are, 1, the ratio, the premium ratio. Currently, we all know with ACA it can only be 3 to 1. So the oldest person can't pay 3 times more than the youngest person's premiums. This would allow states to have a higher variance of 5 to 1. So the oldest person would pay more than 5 times the youngest person. The second item waiver that the states could request, and again this is that controversial one, is the fact that if you have pre-existing conditions and you opt out of coverage for more than 63 days, when you hop back in, you could be charged more. Now, they would have to set up like a high-risk pool. Historically, high-risk pools have been tried. However, with high-risk pools, they typically don't work because it just gets more expensive that no one can afford. So that's not a very popular concept, and that's where people are saying if you have pre-existing conditions, and you had a short lapse based on a job situation, et cetera, that you would be penalized because you have a pre-existing condition. The third and last waiver is that states could define their own essential health benefits. So a lot of people state, well, the insurance is too rich. Why is the young male paying for maternity coverage when that's not something that he's ever going to need? Versus ACA that's kind of has this base level essential health benefits that spreads those costs throughout the whole pool. Now, you should be aware, however, that to get the 51 votes to make changes, the changes have to affect the budget, and there is some concern that all the changes we just itemized don't necessarily meet the special budget rules of reconciliation, so some of these items might not be allowed. So having gone through that, the next thing we want to talk about is a Congressional Budget Office. You may have heard a lot in the news recently. It's called the CBO, and this is a nonpartisan group that looks at the cost of a bill. So on May 24th, they came out with a pretty damaging critique of the GOP House bill that was approved on May 4th. And some of the big items there are it would create 23 million additional uninsured Americans by 2026. So that is what a lot of Republicans are struggling with, is going back to their states and being responsible for less people having insurance than not. Because that is one thing ACA did, is it gave access to care. The second item is it would lower premiums potentially for younger and healthier people, but the way it's doing that is actually allowing for less services. So it's not like you're getting the same amount of insurance for lower cost. You're getting less, and therefore it costs less. The third bullet point is also the other controversial one, where it's going to cause potentially, for the CBO at least, that unhealthy, poor people, older consumers would actually have higher premiums and higher out-of-pocket costs, which is not a very popular with some, legislators and their constituents. The good news is it would be paying for less things, so the AHCA would decrease the deficit by $119 billion over 10 years. A controversial thing that got a lot of the senators' attention is that one statement in the CBO report said that 1/6 of the population in non-group markets would become unstable by 2020, which will be here before we all know it. And a lot of those areas were actually Republican states, where the individual market, the exchanges, et cetera, would just not be functioning based on the changes per the AHCA. Now, some GOP members are claiming that the CBO report is inaccurate. No one's perfect. They've definitely made mistakes before, and that's what some GOP members are stating about this kind of scathing report that came out that did not support their AHCA bill that they've now kicked over to the Senate. So that leads us over to the Senate. So where we're at right now is there's a 13-member panel that has said, hey, we've received this from the House, but we don't like it. We're actually just going to start from the beginning and rewrite our own modest version of the House plan. So some of the key items that the Senate's trying to deal with is that Medicaid expansion and spending. Again, that's a polarizing issue within the GOP senators themselves. How do you keep the ability where individual insurance is actually affordable through either tax credits or current subsidies, et cetera? The Senate has no interest actually in the high-risk pools. They believe kind of been there, done that. It doesn't work too well, so they like the idea of reinsurance to insurers to cover these people with higher claims, but we'll see what they actually produce. And then they want to, of course, control rising premiums for those older and poorer people, especially those older Medicare folks that are big voters. And then the last thing, of course, is the controversy over, how do we protect those pre-existing conditions where people can retain coverage even if they may be sick and they don't, spiral into a very high cost situation that doesn't cover a lot and they're high utilizers for care. So what the Senate's stating or proposing now is maybe they do like a two-step process. They can't completely repeal ACA because they don't have the 60 votes. They're stuck with this reconciliation process requiring only those 51 votes, but all those changes have to affect the budget. So what the Senate is proposing is maybe a two-step process where they stabilize the premiums and exchanges for the next couple years. They would keep those cost-sharing subsidies that reimburse certain members when they do actually use care, so it helps to pay for those copays and deductibles. But it would phase out the mandate. It wouldn't end it abruptly. And then it would hopefully repeal in 2020, so more of a moderate phase out. Within the Senate, however, the GOP leaders are not confident they can get 50 votes. They struggled with this on the House. They finally did pull it out, but the Senate's not very confident that they can do the same. And again, in summary, there's just two basic philosophies within the GOP party. Some people want to, acknowledge that, hey, ACA, it gave access. We are going to have struggle pulling that away from anyone. Let's try to make changes to it. And other GOP members are, it's just completely against the concept of ACA, and they can't completely repeal it, but they want to make some drastic changes and or create these state waivers. But that CBO report said that those state waivers could be the part that destabilizes the market. So that's where we are. We'll see. Their goal is to try to get something to vote on before the August recess, so the end of July. We should kind of know where this stands. So we will keep you posted. Now, the carriers, the health insurance plans, the association, was kind of pushed out of the negotiations on the House side. The House didn't listen to them, didn't, ask them for opinions, et cetera. So the American Health Insurance Plans have sent a letter over to the Senate requesting what the insurance companies would like to see. So a couple items real quick is, they do want to make sure that insurance can be affordable. They do like the concept of protecting the guarantee issue and the pre-existing conditions. They don't, think that people can't have insurance just because they have certain situations going on. They like the community rating. They probably would like that 1 to 5 versus a 1 to 3 ratio, but they like the community rating where the risk is spread amongst everyone. They say that it's very, very important for the government to continue those cost-sharing subsidies and to reimburse those carriers for those. Also, number 5 there, you'll see that they want to encourage continuous coverage. That's key for any insurance company to not have that adverse selection where people hop onto an insurance plan when they're sick and they need the care, and then they hop off and don't pay the premiums when they don't. So that's, of course, very important for the carriers themselves. They, too, support the reinsurance, so help reimburse the insurance companies for the high risk versus creating these high-risk pools that tend to death spiral out of control. It's number 7, you'll see, is very important to the carriers. They want to eliminate that health insurance tax, not popular with them at all. They, of course, would like to see, number 8, increase for subsidies for younger people. Let's attract those younger, healthier people into the pool to spread the risk amongst more people. That would be key for the carriers. And, of course, what they're desperately seeking for right now is please hold off on any major changes until 2019. All the insurance companies have to file their 2018 rates in the summer. Some of them have already filed them now. I'm sorry, they did have to file in June. It was punted from March. So this is key for them. They're trying to file rates and not know what's going on is pretty hard as insurance companies with their actuarials. And then they do like the idea of giving the states more flexibility on handling Medicaid versus at the federal level. All right, so that moves us over to our big topic, which is California legislation, which is definitely constantly changing. There was some information released last night that we tried to add into this presentation today, and we will definitely keep you posted on how this is progressing because we should have some additional information by the end of tomorrow. So in California, it started on the Senate side, and there's a proposed bill called SB 562. It's called the Healthy California Act. Essentially, this is a state-run single-payer system. So a reminder for all of us, because it can actually be confusing, single-payer versus universal care. If you look to the right side of the slide, you'll see that universal care, or maybe a public option is what you want to call it, is when the government offers like a base level insurance that is provided for everyone. But there's alternatives with insurance companies. So they're not the only way you can get care. However, what California is proposing right now is a single payer situation where it would actually replace all insurance companies, Medicare, Medicaid, etc., and the state of California would be the entity paying the claims. There would be no other insurance programs allowed in California. So the controversies from the different countries that have put single payer in place where there's no other options is it does tend to increase wait times, so you have a hard time getting to that doctor, getting that lab test done. The stories about the people coming from Canada to the U.S. to get their MRIs done because they're on a long wait list in Canada, depending on where they live. Potentially it rations care, decreases innovation, increases tax costs because you have to pay for this somehow. It's not quote-unquote free. Reduces jobs. Just think about the insurance companies are no longer around in California. That alone would probably increase unemployment for all those people losing their jobs, including possibly us. The providers potentially could leave the state because first at government levels, which tends not the commercial rates that they're using. They may just actually leave the state. So no carrier really likes being paid at the Medicaid rate costs. They're talking about keeping it at the Medicare rate, which is higher, but even Medicare doesn't pay the full cost for these carriers. So, I'm sorry, the insurance companies, not the carriers, the services, the doctors, the hospitals, that's what I'm trying to say there. Also, it doesn't eliminate paperwork. I mean, if you've ever worked in the Medicare and Medicaid system, these hospitals, etc., have to do a lot of reporting to the government because they have to provide some information in order to be reimbursed for their services that they do provide patients. The last thing listed here is, the controversy that single payer actually doesn't control inflated costs. A lot of people want to point at the insurance companies for causing these higher premiums. However, I think most of us in the industry understand, especially with ACA, that insurance companies' profits on average are 2%, which is, as a dollar figure is very high, but as far as the cost of that insurance premium, not much is actually going back to the insurance company for profit. The real care issue is the cost of care, and I think most people agree that that is the issue that hasn't been solved, and that's why this continues to be the conversation. And the last item here is ACA MLR did help control admin costs. Those insurance companies can't just inflate costs however they want because they have to have either 15% or 20% on the dollar of their care or premiums going back to the carrier or back to the claims. All right, so what is this California 562 single payer healthcare coverage? So as I mentioned, it would actually replace all current coverage. So if you're on Medicare, that would go away. If you're on a group plan through your employer, that would go away. Individual coverage, on or off exchange would go away. Medicaid would go away. So you get the gist that all current options would go away and we'd all have the exact same insurance. So the great news is it's going to cover a lot of services. So it covers medical that we're used to, inpatient, outpatient, emergency services, mental health. It also would add to that, however, dental, vision, nursing home care, long-term care, workers' comp, which is wonderful to have all this coverage, but again, it always comes down to how do we pay for this. The next item is with single payer. The good news is, again, there's not a network of providers that you have to work within in this proposed bill. You could go to any California licensed provider and you would never need a referral. So you can go directly to that neurologist, cardiologist, whoever you want to. You don't have to get permission first. The third item you'll see is that since our coverage as a Californian would be covered through the state, if we were on vacation or business, et cetera, outside, there would be coverage for that as well. Now, the fourth bullet point is pretty controversial because the currently states, as the bill is written now, there's no authorizations required. So I could go directly and have as many tests done. So this is going back to that whole fee-for-service concept that insurance, for the most part, PPOs have gone by for years and years. But the controversy is that this concept drives up costs. So, doctors and hospitals are only reimbursed if they actually provide services. So sometimes they may actually do more services than really necessary just so that they can get reimbursed. So this is a big probably cost driver in this SB 562 is not having any, cost containment on care. You can go anywhere you want to, you can have anything done you want. There's just no restrictions, at least at this point in time. And the best news in addition to all that is that when I actually use the services, I don't have to pay a premium to have it. It's quote unquote free. And there's no out-of-pocket costs. There's no copays, deductibles, co-insurance, nothing. Everything's covered. But I keep saying quote-unquote free because the money does have to come from somewhere, clearly. A couple items more on this bill with California as it's written right now is it would cover every resident regardless of income. So even, the wealthy members would have to get their insurance this way. They couldn't opt out and have a private program if they wanted to. Doesn't matter whether you're legal, illegal, you'd be available if you lived in California. And Medicare coverage, again, everything would be covered by the state of California for everybody. So insurance cannot cover services that the state provided, so that means really the insurance companies would leave the state of California because there's nothing that they could provide because this plan currently, the way it's written, it's so generous. And that will probably lead to this next bullet point where it talks about there's increased potential in California unemployment by 18%. Well, if you think of the Kaisers, Blue Shield, Anthems, et cetera, all those insurance companies that are in the state and all those people that work there, agents, brokers, et cetera, if we all become unemployed, that's going to have a big hit on the California unemployment. And then how's this going to be administered? So the way it's written is it would be administered by a 9-member, appointed panel. And so who knows how the detail of, who's paying claims and how claims are paid and those decision makers. And it's, again, that appointment. It's knowing that anyone votes for to get onto this board that manages this huge cost. So speaking of cost, again, it's not free. The estimated cost that we've seen last week that came out was $400 billion annually. Now, the good news is there is some agreement that we probably already do get $200 billion from current systems, as well as what we get from the feds from Medicare and Medicaid funds. Now, that second item there under the $200 billion is a big risk or a big assumption. We would have to go to the feds and say, may we please use the Medicare and Medicaid funds for everyone, not just Medicare and Medicaid members. So we'd be spreading the federal dollars over people that it really wasn't intended to. So that's a big assumption that the feds would give us that waiver. But if they did, that would help create $200 billion for the $400 billion cost. The second bullet point is, the state would then have to come up with the remaining $200 billion. Where does that come from? And to put that in perspective, Our current state general fund, so all the money we have for education, roads, water, et cetera, is $124 billion. We're talking an additional $200 billion on top of the $124 that we have, and it really, frankly, isn't enough now. Currently, we just added $69 billion in higher taxes to help with the water, education, transportation system that we all agree, does need help, but we've already pushed ourselves for that money. Now we have to come up with an additional $200 billion. So the original cost that was floated around is that every person in California, it would cost about $9,200 per person. If you're family of 5, it's not, $9,200 per family, it's per person. So if you're a family of 5, multiply the $9,200 times 5, you're getting $46,000 in additional California state taxes per year. That does assume that everyone in California is actually paying taxes. Not everyone makes enough money to have to pay taxes, etc. There's various reasons, or some people just don't. So the figure is actually 45% of Californians don't pay taxes. So really you'll be doubling this $9,200 estimate per se. So if you're a family of 5, multiply that by 2. The last item here, this just came out last week, is that the Congressional Budget Office in the state of California said that we would have to increase payroll and income taxes by 15%. Again, this is on top of what we already pay, and we're a state that already has one of the highest taxes in the country. So what just came out yesterday is proponents did release a study that says what they think about all the costs and where the money would come from. So they agreed that the estimated cost would be $400 billion annually to take care of all the all the Californians in the state of California. However, they believe that they could find $75 billion through efficiencies, through basically negotiating with providers, getting the insurance companies out of the way, having that streamlined claim payment, getting better deals on prescriptions, and the insurance companies and Medicaid and Medicare apparently have been able to get in the past. So they think that that would lower it. And then they have a little higher estimate. They think $225 billion come from current federal and state programs, where the Senate office said $200 billion is what we had. So per the proponents, that would only leave $100 billion to generate, and they're stating we could make that up in taxes on both businesses as well as all of us through California sales tax. It would be 2.3% on all businesses. Now, businesses under 9 wouldn't have to pay anything. Business under 19 would pay less than businesses of 20 or more in the state of California. And then we would all have to pay 2.3% on sales tax for most items. There's some more details that they released there, but again, put it in perspective, this $100 billion is almost completely what our general fund is today that we have for education, roads, water, et cetera, et cetera. So there's a lot of people opposed to the SB 562, as you can imagine, and they're coming from all different sides. So the Chamber of Commerce is quote unquote stating this would be the #1 job killer in the state of California. Doctors, hospitals, they don't like this concept. The carriers, of course, and including the nonprofit carriers. So for example, Kaiser and Blue Shield are not proponents, even though, for example, Blue Shield's been open to more creative situations in the past, but the way it's written right now is 562 single payer is not the option that they think would be helpful. And then of course most agents, not trying to speak for everyone, feel that it would be not a good thing for California. So where we're at, as I said, the deadline to vote in the Senate is by Friday, June 2nd. So if it doesn't get out of the Senate, then this would dissolve as it's written today. Last week it was made a change that in order for this to go through, it would have to find the funding for it, which we just kind of covered. So what that really means is it could actually get passed, but nothing could change because they have to get 2/3 approval vote in order to increase taxes, and that's really difficult to do, especially the tax figures we just covered. The next item here is, I think most people will agree that ACA actually provided access to care, but it didn't help people with the cost of care. So that's what we're all trying to figure out. How do we really solve the real issue? So until that's done, the health care debate will continue on, whether it's at the federal or state level. There's a strong sense that if the feds do pass something that looks more like a repeal of ACA, then California will be more motivated to pass legislation and vice versa. Now, our current governor Governor Brown is pretty conservative fiscally, and he's already stated that he'll veto SB 562 if it actually hits his desk because he just doesn't see how in the world we can pay for it. But the conversation, again, will continue because the healthcare costs are still not contained. And the most likely next governor in California right now, Gavin Newsom, is very supportive, maybe not of this as how it's written, but of some, single payer or some other different option. So, we could all have a long debate on this, but, some options that we always hear of how do we really help the cost of healthcare is, creating that transparency, the cost of care and services. We've all said it, you know exactly how much you're going to pay for anything else you buy, but you have no idea ultimately the cost of that surgery or test that you have done, and you just have it done, and you don't really have the information to make better decisions on which providers you want to go to with both quality and cost. Information on pay to providers based on quality of care, not that fee-for-service model that SB 562 wants to do. You include the option to have that innovation that we all want, especially health is the most important thing we have in our lives, right? I want to make sure that we do have good doctors that are looking for better ways to take care of us. So pay them based on quality of care versus the quantity. The huge topic right now, and everyone agrees, is the prescription drug costs are getting out of hand. However, they do need to have fair prices to encourage that research and development. They probably don't need as much advertising money. That might help alone. We'll also have a part to play in this, our lifestyle choices. Are we all getting those 10,000 steps and eating the best diet that we should? Probably, I'll speak for myself, not. But we do try, but we could all have a little part in this to help improve the need for healthcare, as well as guarantee access. I think most people have come around to everyone should be able to at least have an option of some base level, and then maybe you can buy up or go from there. Always creating a choice is kind of the American way for most people to have that choice of carriers, providers, and plans, and that creates that competition, which creates better service levels and better prices typically. Also, what works pretty well is the employer coverage that most of us, sell day in, day out. Most Americans actually get their coverage through their employer, and if we keep those tax incentives to do so, that system will stay. We need to make sure that we're not making it so difficult on these poor employers to administer health care. However, that might discourage them from doing so. But that system works well, so why change that? Why don't we just make some tweaks to it to make it better for most people? Also, those insurance companies do believe you need to mandate coverage so that you just don't jump on the system when you need care and then jump off. That would not let the insurance company stay in business. And so there needs to be steeper penalties than what ACA created for those that actually choose to go without. But there needs to be a way for those people that want care, that have low income, to be able to afford it at the same time. So I know we're running over here. I'll try to pick up the pace. We're almost done. So what can you do? The number one thing, of course, is to stay informed, and we'll be part of that for you. Stay touched. As soon as something does actually get passed, we'll create good tools for you to help you understand what did get passed, and so you can help support your employers and let them know what they need to do. Be a good resource for your clients. Be a resource for your representatives at the federal and state level. They're not healthcare experts, so reach out to them and help provide that information. They're actually looking for it. And then, of course, it always helps, lobbyists are the American way, so and CAHU to help those lobbyists, fight a good fight, that would be helpful. So 2 more minutes here. Information on B&P. So we have released that have been around for a little bit, but want to remind people of it, and one coming in June. So if you're using eCentral for your groups, you can currently, once the employees have gone through that enrollment process, you can quickly now, through connectivity, send that submission directly from eCentral to BP Underwriting, and we can walk you through the details of that. What's coming in June that we're also very excited about is that in BP Quote, which is Health Connect, once you quote a group and you sell it, you'll quickly be able to export the census data and the sold rates and plans into eCentral to help set that group up even quicker than it takes today, or you can always rely on B&P to do that work for you. Just let us know. So we're very excited about that connectivity. 1, up front, helping you get groups up and running faster, and then 2, once the group is through the enrollment process, submit it to us. And the last thing, I think I'm out of time, but I wanted to show you We have created these new generators on our website. All the stuff we create is under something called Back Pocket. And for example, if you go under networks, we have quick ways that are customizable to search for either medical groups or hospitals. So if I go to medical group comparison, and then, oops, sorry, I think I'm going too fast and I ran out of, let me try that again. There we go. All right, so if I wanted to say, okay, which medical groups maybe are in Contra Costa County for, say, Anthem, Prune Buyer, or actually that's a bad example, Anthem, California Care, the full network HMO, I can compare it quickly and it will give me the results. And then I can say this is a PDF sent to my client. So our current tool has all the carriers, all the counties. So this is if you want to kind of break it down or compare just maybe 2 carriers, say Anthem and Blue Shield. That's a way to quickly do that. And we're coming out soon with the underwriting guidelines and the light plan comparison. So we're basically making all the tools that you know us for to have customizable features within the website. And the very last slide today, thank you very much for your attention and time, are Anthem. So Anthem is encouraging groups to use employer access. We're getting lots of questions about this, so I want to make sure that you guys know so you can communicate to your groups that employer access, it's the same features that they've always had, they're just enhancing it. And now they're making it to where the group or you can actually go online and do adds and deletes. But unlike Blue Shield, they're not forcing everyone to do it that way. It's logical, probably makes the most sense. But if your group, for whatever reason, doesn't want to do it, they don't have to. And what's hot off the presses with Anthem in particular for specialty, meaning dental, life, vision, if you're selling the specialty standalone, or better yet, adding it to an enforced medical group, you do not need to submit a DE9C. With Help Then, if you haven't heard, they've recently announced that although in 2017 they've had those portfolios enhanced choice A and B, now you can sell actually any metallic plan and any network side by side. Even you can pick one plan from enhanced choice A and another one from B. That's currently fine. They're doing a promotion through November with that. And they have lower participation down to 35%. The trick is you cannot be selling the PPO Platinum, Gold, or Silver plans to get the 35% participation. You could only be selling the PPO Bronze. And lastly for today, a reminder that UHC has introduced 2 HSA plans for July that we're all excited about. They were being pushed pretty hard for this. So they brought back a third portfolio, that Choice Simplified 2, and it includes an HSA 2000 that everyone was begging them for. And they had a 4800 HSA, but it wasn't full network, and now they do have a full network HSA 4800 and a full network HSA 2000. So I've gone through everything we wanted to cover. I think I'm out of time for questions. I apologize, but we'll certainly get back to you. We will be sending the copy of this presentation to everyone that participated today. And if you have any questions, let us know. We're certainly there for you to keep you posted. Take care and welcome to June.